Estão vendo a página?
Sim.
Sim.
Então, pode começar a gravar. Só me avisa quando começar.
Já comecei.
Ok. Então, bom dia a todos. Hoje damos início a mais uma sessão do SIG Farmaco, hoje com um convidado internacional. Lembrando que o SIG Farmaco é uma iniciativa para o uso da estrutura de vídeos e webconferências da rede RUT para reduzir as distâncias geográficas e estimular a integração e colaboração em ações de ensino e pesquisa em farmacologia e terapêutica no Brasil. Nós ficamos sempre muito felizes porque temos mais de 54 instituições participantes, sendo 21 delas com rede física da RNP. Né? E aqui alguns informes que nós solicitamos que os participantes mantenham os microfones fechados e também há a possibilidade, quem tiver interesse, que na parte inferior da tela vocês podem clicar no Closed Captioning e ter a legenda em inglês, espanhol e português. Tá? Outra solicitação é que vocês informem pelo chat o nome de vocês e a instituição de origem de cada um de vocês. Eu sei que vocês tiveram, como mudou o sistema para o RCC, muitos estão tendo dificuldade de entrar na página, nas apresentações, e lembro também que o registro de presença ele tem uma nova regra. Então, para a entrada, vocês, para ter inclusive o registro da presença, vocês devem entrar na reunião pelo rccrnp.br ao vivo, devem se cadastrar ou fazer o login para quem já tem cadastro, né? E no caso, aí vocês com isso, vocês terão acesso ao registro de presença. Né? Vocês podem também entrar via o CAF. Né? Então, a orientação para o registro de presença é essa. Né? Então, no caso, quando vocês entram já no RCC-RNP/BR ao vivo e vocês selecionam o SIG Farmaco, vai aparecer essa tela que provavelmente já está clicado, desejo registrar minha presença nessa sessão. Com isso, uma vez isso estando clicado, vocês vão ter o registro da presença automático e depois vocês poderão buscar o certificado na parte restrita depois do login. Então, a estrutura da sessão, só relembrando, essas boas-vindas e informações gerais que eu estou apresentando, que vai demorar uns 3 minutos, a apresentação do palestrante, né, que será feita pela professora Alexandra Acco, que indicou o nosso convidado, então agradeço a professora Alexandra Acco, a apresentação do professor doutor Andreas Kremer. Eu estava tentando não lembrar o nome, mas sim a pronúncia, né? Kremer, e o debate depois, com 35 minutos, o debate com os participantes e, por final, um encerramento da sessão. Então, aqui nós temos a apresentação, né, do tema, que será introduzida aqui pela moderadora da sessão, que é a professora Alexandra Acco. Então, passo a palavra para você, Alexandra.
Ok, obrigada, Roseli. Então, eu vou fazer a apresentação do Andreas em português, para ficar mais fácil. Então, o Andreas é formado em medicina na Alemanha, que é o seu país de origem. Ele foi residente no Departamento de Gastroenterologia e Hepatologia da Ludwig Maximilians University, ou algo parecido com isso, de Munique. Fez doutorado e pós-doutorado na Universidade de Amsterdã, na Holanda, onde trabalhou com mecanismos moleculares de prurido em cholestasis, que é o assunto que ele vai apresentar hoje. E foi nessa ocasião que nós nos conhecemos, nós trabalhamos um período juntos na Universidade de Amsterdã, por ocasião do meu pós-doutorado também. E atualmente, o Dr. Andreas é professor e cientista clínico de hepatologia no Departamento de Gastroenterologia e Hepatologia do Hospital Universitário de Zürich, na Suíça. E ele é chefe adjunto de hepatologia e investigador principal de vários ensaios clínicos. Então, ele tem bastante experiência laboratorial e também com ensaios clínicos. E ele dirige um grupo de pesquisa sobre doenças autoimunes e colestáticas, como fibrose hepática, hepatocarcinoma, carcinoma colangiocelular, e envolvendo também o eixo intestino-fígado e suas manifestações extra-hepáticas, tais como prurido e fadiga. E prurido é o foco dessa palestra de hoje. E no início da palestra, aliás, dessa conferência, ele me falou que ele ainda mantém o grupo de pesquisa numa outra universidade na Alemanha, onde ele trabalhou por vários anos, depois ele acabou o pós-doc, antes de se mudar para Zürich, então ele ainda mantém esse grupo de pesquisa. Então ele tem um grupo de pesquisa na Suíça e outro na Alemanha. Isso nos mostra que ele tem uma capacidade de trabalho que é muito grande. Isso eu percebi desde a época que eu conheci o Andreas na Universidade de Amsterdã. Ele tinha uma capacidade absurda de trabalho, fazia experimentos com cultivo celular, com animais, Western blot, PCR, tudo no mesmo dia, tudo muito bem organizado. Então ele trabalhava muito e a sua produção científica mostra muito isso. Ele é extremamente produtivo e tem publicado bastante. So, Andy, thanks for being here with us in this meeting, in this national meeting. I made your presentation in Portuguese to be easier to the audience. So, but I was talking that how hard work are you in the lab, and how serious are you in your research? So we are glad to have you here. So we can listen to you now. Thank you.
Dear Alexandra, dear colleagues, thank you very much for this very kind introduction and the opportunity to participate in your national meeting. And it's a real pleasure to present this talk on pruritus of cholestasis. I try to share my slides and I hope that you can see them now.
It's fine, thank you.
That's fine, wonderful.
Okay, I will turn off my my camera so you can see only, okay?
Wonderful. So, dear colleagues, ladies and gentlemen, you're all aware of pruritus, in particular the acute forms of pruritus, for example, when you get in contact with this mosquito or this stinging nettle. And what you experience is a reddish swelling, which is itchy. And what do? You scratch that itch. And you're all very smart and you know that these acute forms of pruritus are mainly mediated by a mediator released by mast cells. And the important one is here certainly histamine. Now, I would like to illustrate to you that pruritus experience can be very different. And I try to get this movie started. So those of you who are a little bit of an older age know this movie with Baloo the bear, and Mowgli is the child, which is growing up in the rainforest. And when you experience an itch, you scratch that itch, and this can be very, enjoyable, relaxing. And there are mirror neurons in your brain which make you scratch as well as Mowgli does here when you see another person scratching. And interestingly, if you scratch that itch, this is a pleasurable feeling. If you scratch your skin now on a surface, and you can do that right now, it's not pleasurous. And that's very intriguing, that this each scratch cycle is some kind of rewarding system, which makes you feel scratch in a chronic situation. Now, to illustrate to you that this pleasurable feeling of an itch, which occurs once in a while, can be very life-destroying, should be shown by this night movie of a PFIC adolescent, which scratches all over his body during night. And you may imagine that the night sleep is strongly disrupted, the quality of life is strongly diminished, and even parents scratch their children throughout the night to make their children fall asleep, and this can strongly destroy, you know, not only the quality of life of the affected person, but also of whole families. And indeed, in these chronic pruritus situations I'm interested in, and these two pictures should just illustrate to you how, you know, destroying and unbearable such a chronic itch can be. And I'm interested in the mediators of these chronic situations. What is the histamine equivalent in these forms? What is the itch factor here in these cases? And to illustrate that to you a little bit, is chronic pruritus really such a problem? And these are just some epidemiological data showing that, you know, 8% of the general population here, for example, investigated in Norway, suffer from a moderate to severe, so from the intensity already quite, you know, dramatic chronic pruritus. If you have a skin disease, almost every second patient will suffer from chronic pruritus. And even under healthy German employees, the prevalence was more than 15% in a large cohort, and the lifetime prevalence is almost, you know, affecting every fourth human being. So indeed, this is a significant relevance, and in contrast to chronic pain, where research started 30 years ago, we are in our infancy here in the molecular and pathophysiological understanding, and this graph should illustrate to you a little bit how an itch works. How do we feel that itch? And this graph illustrates to you that there are sensory neurons which are located here in the skin. These nerve endings are located here between the keratinocytes, and these blue neuron is activated by histamine. And once, you know, histamine is released, this neuron is activated, and the action potential is mediated to the dorsal root ganglia, where the stomata of these sensory neurons are located, and then to the spinal cord, where there's a complex interplay between interneurons, and then the signal is further transmitted to the contralateral spinothalamic tract, where various areas in the brain are activated. Now, previously it was thought that sensory neurons would, you know, be able to transmit both pain and itch. And only within the last 15 years, one could identify that there are specific subsets of sensory neurons which respond to certain itch stimuli, such as histamine, but not to certain pain stimuli, such as mechanical pain. And more recently, one has identified further subgroups which do not respond to histamine, but non-histaminergic stimuli, which I will come back later during my presentation. So where we do not see the classical wheal and flare reaction in the skin, where the skin looks very normal, but still is very itchy. And among these non-histaminergic stimuli are various drugs also, which are capable of activating these red neurons here and use more or less similar signaling pathways. In the meanwhile, we have understood that there is a complex interplay between the cells located in the close proximity, such as keratinocytes and immune cells with these nerve endings. Now, what do we know about this chronic itch in liver disease? We know that various compounds accumulate in a chronic liver disease, in particular if we have a cholestatic liver enzyme pattern. And among these are bile acids, and bilirubin metabolites, but also endogenous opioids, progesterone metabolites. And we have understood that there are sensory nerve endings which exhibit specific G protein coupled receptors, which can be activated, which I'll come back to you in a minute. And these neurons then are likely to mediate this itch signal again to the brain. I'll come back to this interplay on the spinal cord level, and then the neurons in the brain are activated. We feel an itch, we scratch that itch, and that again causes damage, local inflammation, and this is part of the itch scratch cycle. Now, potential mediators, I will come back to that, are lysophosphatidic acid, bile salts, and certain metabolites which accumulate in patients with chronic liver disease. Now, I told you that pain and itch are mediated by separate subsets of neurons, and still there is a close interplay between these signaling pathways. And to illustrate that to you, here the upper part in the scheme is the sensory nerve endings, which are located in the skin. And from the left, from the skin, we go via the spinal cord to the brain, where we feel that itch. And down here, we have a signaling pathway for pain. Now, what do you do if you feel an itch? You scratch that itch. And why do you do that? Because upon scratching, you activate these pain neurons. And you do that because these pain sensory neurons inhibit signaling via this itch signaling pathway. So these neurons are under an inhibitory control of these pain neurons. And so when you activate pain neurons, you augment this inhibitory control and get control of the itch again. Other ways of doing that is increasing temperature, so heating up the temperature, or cooling temperature. So, when you put an ice package on your skin, you also activate these pain neurons, which then augment this inhibitory control. Another way to prove that is to disinhibit this inhibitory control, for example, by opioids, muopiates, anesthetics. You lose this inhibitory control. You don't feel in pain, but suddenly an itch may occur, particularly with older opioids and anesthetics, which were applied close proximity to the epidural or peridural system. This was quite impressive. So women, for example, during delivery didn't feel the pain, but an itch. More modern opioids don't do that or activate other subset of opioid receptors, such as the kappa opioid receptor system, which intriguingly, inhibits the pain signaling, but keeps this inhibitory control. And that's why kappa opioids are an interesting target, because they do not only address pain, but also at the same time can improve chronic pruritus. And I'll come back to that class in a minute. Now, when we talk about such a symptom, we always have to think about the patient. And this picture should just illustrate to you how we should approach a patient with chronic pruritus. This is the back of a young patient. You may appreciate, you see a lot of secondary excoriations, efflorescences, some kind of prurigo here. But what is interesting, that aside these chronic scratch marks, there is an area here in the back which is free, which is unaffected. And this so-called butterfly sign illustrates to you that the chronic itch has developed on primarily unaffected skin. And this is very helpful. So two things you should always ask your patient. The first is, has the itch started on skin that was primarily affected by any kind of alteration, eczema whatsoever, or is the itch primarily occurring on normal looking skin? And the second thing is you should always look at the body surface of your patients and investigate that and control for such a butterfly sign. And this helps you very much to identify or to analyze, your patient with chronic pruritus. If primarily affected skin is present, send the patient to the dermatologist. If you have pruritus on primarily unaffected skin, you should think about systemic, neurological, or psychiatric disorders. And of course, when you have chronic scratch lesions, the differentiation may be somewhat difficult, and you may, have to figure out what is the underlying cause. And I would like to guide you briefly a little bit through pruritus on primarily unaffected skin. What are the causes here? This figure illustrates to you what are the main causes. Among others are hepatobiliary disorders, chronic kidney disease, not only patients on dialysis, also patients pre-dialysis suffer from that symptom. Myeloproliferative neoplasms, illustrated here, are commonly associated typically with a kind of aquagenic pruritus where water contact causes insignificant itching. Many drugs may cause that as adverse event. We have various endocrine disorders, and we have iron deficiency as another important factor. Now, today I would like to go into detail of pruritus and liver disease, and here are the liver diseases illustrated to you in regard to the site of injury in the biliary tree, because commonly pruritus is present in patients with cholestatic features of a liver disease, and it may be a purely secretory failure of the hepatocyte where certain transporters in the canalicular membrane of a hepatocyte are dysfunctional, as we know that this is the case for intrahepatic cholestasis of pregnancy, or hereditary cholestasis syndromes may also be caused by steroids, hormones, toxins, drugs, or alcohol, or by certain viral hepatitis. The immune-mediated destruction of the smallest intrahepatic bile ducts, as seen by primary biliary cholangitis, are also typically associated with this symptom. And then we have various more obstructive cholestasis syndromes, such as sclerosing cholangitis, benign and malignant disorders. And to illustrate to you, is that a real problem? We have observed, epidemiological data, for example, in these patients with primary biliary cholangitis, and you may appreciate that every second patient reported on pruritus, aside many other symptoms such as fatigue or arthralgia. And if patients report on pruritus, we see that the more intense the pruritus is experienced by our patients, this is typically done on a verbal or a numerical rating scale ranging from 0, no pruritus, to 10, the most intense pruritus you may imagine. If you correlate that with quality of life measures, you see a nice correlation between the intensity and the quality of life in those patients. So one typical feature in pruritus and liver disease is that if the skin of the palms and the soles is unaffected and is very itchy, this is almost pathognomic for liver disease associated pruritus. So if somebody reports on that, you should always think about the liver and perform further investigations. Other clinical features are that progesterone metabolites, so the second part of the menstrual cycle, or under hormone replacement, pruritus in female patients with liver disease typically worsens. Now, regarding the therapeutic possibilities we have in our patients, I would like to illustrate that to you in regard to the facts which we know about these potential pruritogens in liver disease. And what we do know is that these pruritogens accumulate in the systemic circulation. And this is due to the fact that patients unresponsive to any drug treatment may undergo a liver dialysis, a so-called albumin dialysis, where albumin-bound particles in the circulation can be, transferred from a semi-permeable membrane from the bloodstream to the albumin column. And by this removal, you can strongly improve itch intensity in these patients. And when pruritus comes back in weeks to months, you can repetitively do this very invasive procedure, of course. And also the exchange of plasma, the plasmapheresis, is equally effective, here shown in a study in cirrhotic and non-cirrhotic patients. What else do we know about these pruritogens? The enterohepatic circulation plays a major role in the pathogenesis. What is the enterohepatic circulation? Bile is produced by the liver, secreted into the gut lumen, and at the end of the small intestine, the terminal ileum, biliary particles are reuptaken, in particular bile acids, for example, by an illegal bile acid transporter, abbreviated as IBAT, and then transported via the portal bloodstream to the liver. And there, the substances again act on hepatocytes and cholangiocytes. Now, when you interrupt this enterohepatic cycle, you have a strong improvement, and that's why we know this enterohepatic cycling is important, that these pruritogens are indirectly or directly secreted into bile. And also here, from clinical experience, when you have a patient refractory to any other drug treatment, you can place a little drain into the bile duct and drain out of the bile out of the body, which is typically produced during 24 hours, several hundred ml. And this leads to a dramatic intractable relief of intractable pruritus, in particular in BRIC and PBC patients. This graph should illustrate to you that the patient have a dramatic improvement. However, when you have to remove this drain after days to weeks, pruritus comes back in these patients. So this is only an experimental rescue regimen. Still, it's very impressive. The patient will tell you the next morning, it was the first night I could sleep again. So impressive improvements you may achieve here. Other ways of interrupting the enterohepatic cycle are anion exchange resins, which binds biliary particles in the gut lumen. And the most common one is cholestyramine, which may be given to these patients in doses 4 to 12 grams. Be aware that many other drugs are bound in the gut lumen, in particular the baseline therapy, ursodeoxycholic acid. So this needs to be separated from other drugs. The data on efficacy is very weak, and indeed, a more modern anion exchange resin, cholecyvilam, which binds bile acids much better compared to cholestyramine, was not superior to placebo in a randomized controlled trial, questioning the first-line treatment of this only in-label drug, cholestyramine. Still, this is the recommendation because it's the only in-label drug, and all other drugs I will mention to you are off-label regimen. What else do we know? We know that pruritogens are biotransformed in the liver and or the gut. Why do we know that? Also here, anecdotal reports on patients being under rifampicin treatment for tuberculosis had a dramatic improvement in pruritus. And how does that work? We think that rifampicin binds to a transcription factor, the pregnain X receptor, so it has off-antibiotic treatment effects. And you know that rifampicin induces cytochromes in the liver, in particular 3A4, but many others as well, and drug metabolism is dramatically altered. But also, conjugation of bilirubin is increased, MRP2 as transporter for conjugated bilirubin is increased, MRP3. So the secretory function is improved under rifampicin treatment, and for randomized controlled trials have proven efficacy of this drug. And you may appreciate that the standard mean difference was -1.6 in this meta-analysis, illustrating a benefit for rifampicin treatment. Indeed, I would think that this is the most efficacious drug treatment we have so far. That's why rifampicin was always suggested as second-line therapy in doses where 150 to 300 milligram are efficacious in most patients. You often don't need the antibiotic dose of 600 milligram. Be aware that hepatotoxicity may occur in up to 5% of patients, and of course of the drug-drug interactions, which may limit the use, in particular patients with oral anticoagulants, antiepileptics, and other drug treatments. Now there is a novel approach in chronic liver diseases, and these are fibrates. And fibrates actually act also on transcription factors, the so-called peroxisome proliferator activated receptors, the PPARs. They're alpha, gamma, and delta subforms, and bezafibrate is a pan-PPAR agonist, which has been investigated in a randomized controlled trial in PBC, PSC, and secondary sclerosing cholangitis patients, 400 milligram for 3 weeks versus placebo. And patients had to have a moderate to severe itch intensity at baseline. The primary endpoint was itch reduction by 50%, and you may appreciate that after these 3 weeks, 45 of these treated patients had a 50% reduction, showing here again in this graph. This is not a golden bullet. It helps some patients quite well. Others do not have such a significant benefit. But the big advantage of fibrates is that you also improve the underlying cholestatic disorder. At least for PBC, primary biliary cholangitis, we have good evidence that this has a benefit on the underlying disease as well. But also here, be aware that hepatotoxicity occurs in up to 6%. Many patients report a myopathy. Rhabdomyolysis may be a problem if you combine that with statins, and nephrotoxicity on the long run may also be a problem. So in that regard, bezafibrate is a other second-line choice in the treatment regimen of pruritus and cholestasis. And finally, we know that these pruritogens modulate the endogenous opioidergic and serotoninergic system. And why do we know that? Because mu-opioid antagonists improve pruritus. Also here, anecdotal reports that naltrexone treatment improved pruritus in a PBC patient. This was followed by randomized controlled trials, but be aware that the standard mean difference in this meta-analysis is much less compared to rifampicin. It works, but with much less efficacy. That's why naltrexone is only recommended as third-line treatment at doses 25 to 50 milligram. Be aware that very few patients may report an opioid-like withdrawal reactions, so it may be helpful to introduce low doses or a naloxone perfuser first. And sertraline as a SSRI is recommended as fourth-line treatment at doses of 75 to 100 milligram. Now, if you follow this treatment regimen, the vast majority of patients will have a benefit. Still, I would think that every third patient will tell you this is not sufficient. And the question is, what can we offer to these patients if nothing else helps? And in that regard, there are novel treatment options I would like to explain to you. Aside, these invasive procedures such as an albumin dialysis or nasobiliary drainage, I told you, and in some patients, even liver transplantation is still performed purely due to untreatable refractory pruritus in the absence of liver cirrhosis or liver failure. So anticonvulsive drugs, are they helpful? And you know them because gabapentin and pregabalin are well established in neuropathic pain and in chronic kidney disease-associated pruritus. So how does that relate to pruritus and liver disease? And there was one randomized controlled trial investigating pregabalin with negative results, but it was a very low number of patients, 7 versus 6, and too short duration of 2 weeks only. If you treat those patients, the full efficacy will only be seen after 6 to 8 weeks. So this is definitely too short. And these were the results. Indeed, on gabapentin, and here the scratching activity was analyzed, was rather increased compared to placebo, where scratching activity was reduced. So a little bit difficult to interpret data. We did that in a retrospective investigation and observed that, you know, the VAS at the beginning of such a treatment dropped significantly from 8.4 to 2.6 in this retrospective analysis. And this is certainly above the placebo effect one would expect in such a cohort. I personally think it's a very well suitable add-on therapy to other established drugs. In particular, of course, if the kidney function is normal, if the kidney function is not normal, you should adapt the dose of these drugs. In palliative care or before liver transplantation, I always tell my students, you should perform a trial with an opioid antagonist. And why is that the case? Because you may have such a strong benefit that you do not need liver transplantation anymore. This is nicely shown here by this case report by Anthony Jones. And I recommend an naloxone perfusion, in particular, if you have an advanced tumor, which causes, due to metastases, a cholestatic or icteric clinical picture. Start with low doses of 0.002 microgram per kilogram body weight per minute, and then increase or double that dose every 12 hours before switching to oral naltrexone. Now, I told you that the enterohepatic cycle is a very important factor in the pathogenesis, and indeed, you can interrupt this enterohepatic cycle very specifically here in the terminal ileum by inhibitors of the ileal bile acid transporter. And various drugs are currently investigated. They all end on the term IBAT, linerixibat, maralixibat, odevixibat, and so on. And they specifically, remain in the gut lumen, but inhibit this transporter. And they have a good safety profile. They're not uptaken into systemic circulation, but of course cause potentially bile acid-induced diarrhea because the bile acids remain in the gut lumen, are secreted in the colon, and that may cause chologenic diarrhea. Now, is that improving pruritus? And indeed, it's a clear yes. This has the strongest evidence here is in cholestatic pediatric diseases such as the Alagille syndrome. Maralixibat was investigated here in this iconic phase 3 study where patients were put on maralixibat, and after 18 weeks there was a 4-week period of placebo. And what you appreciate is that there is a strong improvement in an itch RO score, a combined score in children, a bit more difficult to quantify, which came back to baseline within 4 weeks. And when those children were put back to the verum, pruritus improved rapidly again, and this, was preserved over a very long time period and even further improved here over time. And these fascinating results were proved in fast track approval by FDA. The drug is called Livmarli for pruritus in Alagille children from an age of 1 year or older. Another example I would like to illustrate to you is odevixibat, which was investigated in these genetic hereditary cholestasis syndromes, progressive, familiar intrahepatic cholestasis. There are at least 6, most likely rather 12 subtypes. And you may appreciate also here, pruritus is strongly approved by 2 different doses of odevixibat. And similarly, bile salts drop strongly from very high levels here, 250 micromolar at baseline. They come down approximately to 200 or a bit above. There is a very strong reduction. And intriguingly, also here we have now Bylvay, which is approved by FDA and EMEA for pruritus in pediatric children from an age of 6 months on. And intriguingly, not only symptoms are improved, but most likely also the course of the disease will be totally different. What we see now from these long-term safety extension data of these clinical trials, that these children do not advance anymore in their chronic liver disease. They normally always needed either surgery or liver transplantation, and this is not the case anymore. So the biliary cirrhosis, the progression towards biliary cirrhosis and decompensation, transplantation is hardly seen anymore. So this is a disease-modifying agent, and that's why we have these early approvals by these legal authorities. Now, there are ongoing studies also in adult disorders, as illustrated here for odevixibat. Now, coming back to the opioids, I told you that kappa opioids have the potential of keeping this inhibitory control. And if that is the case, one would expect that kappa opioids are also beneficial in regard to pruritus treatment. And indeed, if we look at the spinal cord, this is a very complex interaction actually between here various neurons and various itch signaling pathways. I don't want to go into detail, but I want to illustrate that to you that these drugs have been investigated also in liver disease. Nalfurafine is a very old drug. It was investigated in a phase 3 study in Japan. And the benefit here, you may appreciate that that's only 8 to 9 millimeters on a visual analog scale. This is hardly present, but still it was licensed in Japan, but refused by FDA and EMEA. Now, there are more modern kappa opioid receptor agonists, and the most promising compound is difelikefalin, which has been investigated first in a phase 3 study in chronic kidney disease-associated pruritus. And you may appreciate here the green line, the improvement under difelikefalin was significantly stronger compared to placebo. In particular, the very strong improvements, a 4-point reduction is a very strong benefit, was observed in 40% of these patients. So there's a significant benefit here. And so the further benefit is that central neuronal side effects are hardly seen because this is a purely peripherally acting kappa opioid receptor. And also here in liver disease, there is a phase 2 study ongoing with an oral galenic of this compound. Now, one final word to local therapy. UVB light therapy as a non-drug treatment can be efficacious in otherwise untreatable patients. This is a case series which investigated that very severe pruritus, and after a significant number of cycles, the itch intensity was strongly improved in almost all patients. And again, there was also a repetitive benefit if pruritus came back in these patients. So UVB light can be offered to selective patients if that is available, for example, in the Department of Dermatology. So to summarize my talk and my take-home message, I think, and I hope I could show you that there is a nice stepwise approach to treat pruritus in liver disease, starting with anion exchange resins. Rifampicin bezafibrate are certainly the most efficacious drug regimen here. You may combine that in particular with the anticonvulsive drugs, but also UVB light, mirtazapine I didn't mention today. If you have an incomplete response, think about these ongoing clinical trials. I'm not aware whether they also are present in Brazil, but this may be something to consider, in particular the more recently developed IBAT inhibitors. In palliative care, use this naloxone perfusion, or also cannabinoids may be helpful. And invasive procedures include plasmapheresis, albumin dialysis, nasobiliary drainage, and only, you know, for extremely rare cases, liver transplantation may be an option. There's a guideline which we have currently developed for Germany, and I would like to recommend this publication to you who's interested in more details also beyond pruritus and liver disease. This is a guideline on chronic pruritus in general, and I'm also happy to send you a copy of that if you're interested. And with that, I would like to thank you for your attention. I'm happy to take questions.
Thank you, Andreas, for the nice presentation, nice talk. So we can have now some questions, some discussion. And I will start from the step-by-step that you mentioned about the treatment. Usually, for example, cholestyramine, rifampicin. So usually you start just with one this drug, or you can already combine different drugs in the first moment, or it's like a up and down treatment depending of the response of the patient. How does it work?
Yeah, this is a good point. I can tell you how we do that here. Due to the fact that cholestyramine is the only in-label drug, we always use that first. This is due to insurance issues. So we do that for 2 weeks. And as it is in most cases inefficacious and, not well tolerated, because you have, adverse events due to this unpalatable taste, GI symptoms, and so on, you have a good argument to stop that treatment. And then, it depends a little bit, on the underlying disease. If this is PBC, a PBC patient, I would start with bezafibrate. And otherwise, I would rather stick a little bit to rifampicin if that is a feasible drug. And, normally I would, even if pruritus is intense, I would start with a single drug, because if you have 2 drugs given immediately upfront, and you have any kind of adverse events, you're never sure whether it's the one or the other drug. But if you have if a drug is tolerated and you see that the benefit after 2-3 weeks is not sufficient, you may add, of course, a second drug if pruritus is still, severe. And we would, for example, to illustrate that to you, if you have a PBC patient, you add bezafibrate, and pruritus is maybe a little bit improved, but not sufficient for the patient. Then the next step would, for example, for me to add gabapentin or pregabalin, because that takes many more weeks until you see the full efficacy of the drug. And you may add at night some kind of mirtazapine, for example, that you really treat your patients with a drug which improves sleep, which make people fall asleep, rather than to use the older antihistamines. These class 1 histamines which make you feel fatigue or tired in the evening. I wouldn't do that, because sleeping is already a problem in these patients. They are already fatigued, and if you have a drug with an adverse event of fatigue, then you don't improve the clinical situation in such a patient.
Okay. But continue. from what you said now, the antihistamine drugs, but actually the involvement of histamine in this kind of it is not that much important, right? We have another mediators,
Right.
so opioids, as you told, and so this kind of drug, antihistamines, will work somehow.
No, it's purely the placebo benefit you have with antihistamines.
Okay.
I mean, that is what you have with every placebo drug effect. So that will be always present, and this can be, in particular with symptom burden, sometimes quite impressive. And still, I would not consider treating my patients with antihistamines because this, on the long run, it's not helpful. It's just an additional drug. It causes adverse events, and I wouldn't do that. Indeed, we stop all patients, being referred to us with antihistamines as potential antipruritic treatments.
Okay. So we don't have a question from the audience, not yet. I cannot see at least. Okay. So while the people are typing, and about the endocannabinoid system in this kind of eating and pruritus. So in the end of your presentation, you mentioned cannabinoids as possible treatment, but how the endocannabinoid systems, CB1, CB2 receptors can work on that?
Yeah, this is a good question. You see, this is not adequately understood. We know that the CB1 and CB2 receptors are expressed on sensory neurons, but they are also expressed on non-neuronal cells. There has been, case studies on a very few patients illustrating that dronabinol, the active compound of tetrahydrocannabinoid does improve pruritus. And indeed, we do that in our patients, in particularly in the palliative care setting, in advanced tumor stages, or where patients also have pain symptoms associated with it, as it improves pain and the itch sensation. There is no study which has investigated that, but from the clinical experience, this is in many patients well tolerated and quite efficacious. And in otherwise, refractory pruritus situations, we always recommend to add that, and you have to slightly titrate that in. We have that in fluid solutions. You give a few drops in the morning, at noon, and in the evening, and then you increase the number of drops, the number of doses, and until the beneficial effect is experienced by the patient. There are only a few patients who tell us, they cannot tolerate these drugs because of neurological side effects. Okay. But indeed, this is an interesting way of treating patients if that is available.
Okay, so we have some comments in audience. Professor Francois, thank you for the nice translational talk about this largely unknown subject. And Professor Roseli also, thank you for the presentation. And she has a question. Do you think that physicians, gastroenterologists in particular, in the world are aware of this mechanism and these treatment protocols?
Yeah, this I think is an issue where we still have to work on. I think the awareness is not yet there where it should be. We have the situation that the pathophysiological understanding is still only partly understood, but we know that it didn't show you the preclinical data on autotaxin and LPA. but bile acids, there's a bile acid receptor even on sensory neurons. So there's signaling pathways which are not yet addressed by drug treatments. And so for the future, this may open novel, potentially causal antipruritic treatments. And also the recommended treatment ladder is often not used, but this does not hold true for Brazil. It's the same in Great Britain, in France, in Germany. If there's been a nice publication now out from the United Kingdom to illustrate that to you, the vast majority of the patients even not ask for symptoms first. So the physician, the treating physician, don't ask for the symptoms, so he doesn't know whether the patient suffers from that. And if she or he asks for that, the patient is in most cases not adequately treated with the available drugs, even if they are off-label. And this is the big challenge, that we have to raise awareness here and knowledge on this antipruritic treatment regimens, which are available in all countries, because fibrates, rifampicin, it's available all over the world and could be used anywhere as most efficacious drug treatments.
So in this sense, Andy, since you have been working with LPA, Altaxin for many years, so are these molecules potential pharmacological targets for pharmacological drugs against pruritus?
Well, in principle, I would say yes. And when we wanted to publish our results on the autotaxin lysophosphatidic axis, the Lancet asked us, show us that, when you inhibit the signaling pathway, that pruritus is improved in your patients. We would love to publish your paper. But the issue here is that there are drugs which are currently developed, let's say autotaxin inhibitors, lysophosphatidic, LPA receptor blockers. They are mostly investigated in clinical trials in oncology because the autotaxin LPA axis drives proliferation, formation of metastases, vascular effects. And these companies are not very interested if you come towards them and tell them, look, I have very sick liver patients with itch. Couldn't we try your drug in such a patient? They will say, no, we don't want to have any liver-related adverse events in a drug which is, in a currently phase 1, 2, or 3 study. So they are not willing to investigate that, and we will have to wait until we have a drug in label for any other disease entity where we could, in an off-label manner, investigate that in our patients. In that regard, from our preclinical models, we have seen that the LPA1 receptor and 5 receptor are the most promising ones which should be targeted in such a therapeutic approach. Whether the pure autotaxin inhibitor is really efficacious, I'm not so sure, because you would target all downstream targets of lysophosphatidic acid, which is produced by autotaxin, which may cause potentially too many side effects, and that's why I think a more accurate LPA receptor targeting is likely to be more helpful.
I can see. So, and one more curiosity about the last drugs that you had shown in your presentation, that usually are inhibitor of IBAT, so the transporter. Well, I don't know here in Brazil, probably I really don't know, but I think they are not available here. But I can imagine that the price is quite high about this drug. So probably here to be very difficult to put these on the regular use. How is there?
Well, of course, with I think you always have in a rare disease the big opportunity to have a fast approval of drugs. You have an orphan drug, and so an orphan disease, which where you have now a novel drug that facilitates many things for a pharmaceutical company. And of course, there are only very few patients who are treated, and that's why the costs are often tremendously high. Still, what we do is to contact the pharmaceutical companies and ask them for a free trial. So they offer the drug for a free trial, and when during this trial, and you have to document that, of course, adequately, you have a strong symptom improvement in the patient otherwise being untreatable, then we go to the insurance company and tell, look, this drug works. This is much cheaper than performing a liver transplantation. So are you willing to pay for that?
Okay, so this way it's working for you, for your patients,
Yeah.
I mean.
Yeah.
Okay, good.
If the insurance company, takes over the costs in the end, but here at least you have an opportunity to do it this way.
Nice. Okay. Okay. One more question. Roseli said, I had hepatitis C, and I had this kind of itching during the acute phase. But some patients do not have the symptom. Does this depend on the severity of the disease?
Yeah, that's a good point. No, it does not depend on the severity of the disease. It may be present in very early disease stages where we hardly see, liver, fibrosis or even cirrhosis. We do not know actually why this is the case, but it's not the severity of the disease. And the same holds true not only for hepatitis C. We know for hepatitis C, 5 to 15% of these patients not yet being treated or cured suffer from the symptom. If we talk about PBC patients, it's rather 50%. And in these genetic disorders, it's almost 100%. So you see that the symptom burden is very different between this disease, the liver diseases. But it doesn't tell anything whether you have a liver cirrhosis or whether you have no fibrosis. That you do not have to be jaundiced. Bilirubin can be very normal, and still you have a significant symptom burden.
Okay, we have one more question from Darlan. As a pharmacist, a professional who is extremely close to patients, there exists a drugstore mostly at every corner, at least in Brazil. We have a lot of drugstores here. Do you think it's possible for a pharmacist to do the adequate monitoring of the treatment's evolution, tracking adverse reactions, and so on? What would you recommend for this professional?
Well, I think if we talk about rifampicin, the pharmacist is anyway the one who knows more about the drug-drug interactions, and you can easily estimate whether this is a problem or not. Now, if you don't have any drug-drug interactions, the second thing you have to control for is hepatotoxicity. And hepatotoxicity occurs in up to 5% on the long-term treatment. Now, this is something you cannot measure as a pharmacist because you need to draw blood after, we recommend that 2, 6, and 12 weeks to quantify for transaminases and bilirubin. Now, if you have somebody the opportunity to control for that, then I would think everybody should be able to perform the monitoring, because afterwards, after 2, 6, and 12 weeks, I would recommend to control the blood count and the liver enzymes every 3 months. And if you find a physician who collaborates then with you, who takes care of that, then I think yes, definitely. For fibrates, actually, fenofibrate, bezafibrate. Bezafibrate is more efficacious. It's the same. You don't have drug-drug interactions, but you have to control also here for hepatotoxicity after start, 2, 6, and 12 weeks, and then every 3 months. Kidney function may be something, and side effects such as myalgia, that the patient will report that to the pharmacist. They look, it feels like aching muscle, I cannot tolerate that. Then you have to stop again, of course. But a blood control is recommended in my point of view. I wouldn't do that blind, without controlling for hepatotoxicity, even if it's not affecting 95 out of 100 patients.
Okay, thanks for your opinion. So, and one more curiosity. So, from these treatments that you mentioned, all of these, the first line, second line, third line, which one has more long effect, because all this means, or it seems at least, that is like acute treatment, that when you stop, the pruritus will come back. So from these drugs that you mentioned, there's one that can control for a long time the pruritus, or depend of the patient?
From the data we have, I can tell you from, there are no long-term safety extension data from clinical trials whatsoever. All published trials are 2, 3, 4 weeks whatsoever. Now the novel drugs, the IBAT inhibitors, are the first ones who investigate that in a longer period. And there what you see is that indeed you have a prolonged benefit. And even if you stop and restart, you get the benefit again. Now for rifampicin, I can tell you from my own experience, you often only need very low doses, so 150 milligram. I would only start with 150 milligram. And I have many patients who take this antibiotic for years, and they keep, or they control for their symptom burden. I always tell my patients, the treatment aim is not full relief of pruritus. This is something we do not achieve. But the aim is to control pruritus so that life quality is tolerable again. And what we have, on these drugs, that is, long-lasting benefits. When you continue this treatment, I even have some patients who take rifampicin every second day. And the same holds true for bezafibrate, but they have to keep taking this drug. And then in most cases, the benefit on itching is sustained.
Okay.
So we don't see a loss of function here. So we don't see after 12 weeks patients who come suddenly back. So those patients who will have a benefit will have that during they take the drug. It's not that they lose your benefit.
Okay. Okay. Actually, I think we don't have more questions. Roseli is typing. She made a comment. In Brazil, a patient who has itching, even if he does not know the cause, can freely buy antihistamine drugs at the pharmacy, which can aggravate the problem. So really, yeah, we can buy a lot of drugs in every corner.
The same here in Germany or Switzerland. You can buy them everywhere. Yeah, that's true, without any prescription.
Yeah, here's the same. Darla is also typing something. Let me see. Just to wait a little bit. Darla, if you want to also talk, maybe you can just turn on your microphone.
Oh, no, now it's there, no?
Yeah. Just a comment. Absolutely, it might even get the patient addicted to the mild relief. yeah, so this can be a problem to have this free access to different kind of drugs here. So in the pharmacy, I mean, and actually, I don't know how many pharmacies we have here in Brazil, but as he told, every corner we have 4 pharmacies, so it's quite a lot. It's quite a lot. Well, we have almost on our time. I don't know, Roseli, should I come back to you, the audience now? Okay. So actually, I'd like to thank a lot Dr. Andreas for this very nice presentation, and actually to introduce several people from the audience to this this subject that's not common to the people in the pharmacology, unfortunately, because it's very interesting, very nice and useful, and you can have beautiful translational data. So thank you very much for your time, Andy, for being with us. I'm really glad to have this time in this meeting. Thank you a lot.
I thank you for the kind invitation, and a good day to Brazil.
Roseli? Nós não estamos ouvindo, Roseli. Você está mutada ainda.
It's okay. And thank you very much for your presentation. For me, these data are very new, and I learned a lot. And I know that everybody here, the audience, learned too. Thank you. And now I'm going to become presenter and share my slides. Are you seeing them?
Yeah, so it's not on the full screen.
Okay.
Just another comment from the audience. Fantastic lecture. Thank you again, Andy.
Okay, was great. Thank you very much, Andreas. And now some information for the audience. And oh, I have to speak in Portuguese. Okay. Bem, então mais uma sessão do Sig Farmaco, com a apresentação do professor Andreas. E lembrando que nós teremos uma próxima apresentação em maio, pela sala virtual, aqui via RCC, ou quem tiver dificuldade poderá entrar pela conferenceweb.rpn.br. Mas aí, nesse caso, por enquanto, não há possibilidade de obter o certificado. Lembro ainda que os vídeos estarão disponíveis aqui na SBEFT, em sbeft.org.br, Sig Farmaco. Lembrando que, para o registro de presença, no início da próxima sessão, chequem se está clicado, desejo registrar minha presença nessa sessão. Tá certo? A próxima sessão será dia 17 de maio, onde teremos a apresentação da Sandra Elisa Haas, da Unipampa, com o tema Importância da farmacocinética no processo de descoberta de fármacos. Muito obrigado a todos, e a partir de agora nós vamos encerrar a gravação. E mais uma vez agradecemos o professor Andreas.